Hello.
Hello, ma'am.
ஓகேப்பா, ஆடிபிளா இருக்கா?
Yes, ma'am.
ஓகே, நான் ஸ்கிரீன் ஷேர் பண்றேன், சரியா இருக்கான்னு பாரு.
Okay, ma'am.
ஓகே. விசிபிளாப்பா?
Ma'am, இன்னும் ஷேர் ஆகல.
ஓ, சரிதா?
மேம் பவர் பாயிண்ட் சொல்றீங்களா மேம்? இல்ல
ஆமா, பவர் பாயிண்ட் தான்.
இன்னும் வரல மேம். மேம் ஷேர் ஸ்கிரீன் கொடுக்கலன்னு நினைக்கிறேன். வருது மேம்.
வந்துச்சா?
வருது.
ஓகேவா?
எஸ் மேம்.
சரிப்பா. சரி, ஸ்டார்ட் பண்ணுமா? ஓகேப்பா. So today's topic is peptic ulcer. Okay. So this is introduction. When you, after finishing the class, when you go through this slide, you will understand everything. So what are the salient features we are going to discuss is, number one, most peptic ulcers are caused by H. pylori or NSAIDs. And changes in the epidemiology that mirror changes in these basic principal etiological factors. Duodenal ulcers are most common than gastric ulcer, but the symptoms are almost indistinguishable. Gastric ulcers may become malignant, and an ulcerated gastric ulcer may mimic a benign ulcer. Gastric anti-secretory agents and H. pylori eradication therapy are the mainstay of the treatment, and elective surgery is very rarely, nowadays it is almost very rare to get a ulcer case, duodenal ulcer going for surgery. And the long-term complications of peptic ulcer surgery may be difficult to treat. The common complications of peptic ulcers are perforation, bleeding, and stenosis. So the treatment of the perforated peptic ulcer is primarily surgical, although some patients may be managed conservatively. Almost nil. Usually we used to do surgery for perforated peptic ulcer. So coming to the subject proper, what is the mainstay of gastric ulcer is, there is the mucus layer in the stomach. That is a preventive layer. So gastric mucosal barrier only prevents the ulcer formation. So mucosal layer is essential, that is for the integrity of the gastric mucosa. It is a viscid layer of mucopolysaccharides produced by mucus producing cells of the stomach and the pyloric glands. Gastric mucus is an important physiological barrier to protect the gastric mucosa from mechanical damage. and also its effect of acid and pepsin. So normally there is considerable buffering capacity that is enhanced by the presence of bicarbonate ions within the mucus. This only is the protective layer because of this bicarbonate ions. So whenever there is disturbance in the gastric mucosal layer, there is a possibility of getting an ulcer. So many factors can lead to breakdown of this gastric mucosal barrier, and that can be bile, non-steroidal, there is NSAIDs, alcohol, trauma, shock, and tonometry studies show that all of the entire GIT, the stomach is the most sensitive organ for ischemia following a hypovolemic insult. So whenever you are having any stress, even a surgical procedure or mental stress, that can produce changes in this mucosal barrier, and that will produce ulcer. And the stomach is the organ that is also slowest to recover. This may explain the high incidence of stress ulceration in the stomach. So most of the time, whenever there is an ulcer due to stress, also persistently, most of the patients they'll be taking NSAIDs or PPIs, no, not NSAIDs, PPIs, and they will be on treatment for ulcer. And there are two types of ulcer: gastric ulcer type A and type B. So type A is a autoimmune disease, and usually it affects the proximal part. Antrum is spared. Formation of antiparietal cell antibodies. That is the basic pathology behind this. And what happens? Parietal cell dysfunction occurs, and that causes achlorhydria and associated vitamin B12 deficiency. And because of this, what happens? G cells they undergo hyperplasia. That causes raised serum gastrin level, formation of microadenoma of the enterochromatin-like cells, that is ECL cells. That predisposes to the gastric carcinoma. This is one type of gastric ulcer, type A, and that can lead to gastric carcinoma. And second is the type B gastritis. Here, what happens? H. pylori is the commonest cause. What happens here? The ulcer usually occurs in the anctum. Peptic ulcer is most common. Helicobacter pylori, pan gastritis also can occur, and that can turn on to gastric ulcer. So, H. pylori causes type B gastritis, site is anctum, whereas type A is antral gastritis. Type A gastritis usually that is autoimmune affects the proximal part. Here, the anctum is spared. And this is the basic difference between type A and type B gastritis. So acute peptic ulcer, it can be a duodenal ulcer or a gastric ulcer. So what are the common causes? So as we discussed earlier, stress is the commonest, first and foremost cause, and drugs like NSAIDs, that is analgesics and steroids, and the next is the surgeries. What happens? What are the clinical features? So there will be onset of acute pain. There will be abdomen pain. Most of the patients they'll be coming, and your leave letter also you'll be saying no, because of stomach pain. I am taking leave. Yes, no, Arun. I'll call you by name. And so common causes abdomen pain and tenderness. There will be tenderness in clinical examination. In the epigastrium, there will be tenderness. What happens? Patient will complain of vomiting and with or without hematemesis. And treatment usually will be giving intravenous ranitidine or oral ranitidine also can be given in milder cases. Patient used to take over-the-counter tablets that's available, no, either ranitidine or PPIs also nowadays freely available in the medical shop. They will go and get tablets for ulcer. Whenever you are giving injection ranitidine also, it is giving 8 hourly, treated with the IV fluids and either pantoprazole, omeprazole, rabiprazole, all the PPIs. Blood transfusion if there is bleeding. Okay, and during the follow-up, patients are advised to take anti-ulcer treatment for at least 4 to 6 weeks. Patient with the repeated history of ulceration, we will be advising to take drugs for 4 to 6 weeks, either ranitidine, omeprazole, or lansoprazole. So, what is the common cause of gastric ulcer? Here occurs due to imbalance between the protective and the damaging factors of the gastric mucosa. We discussed type A and type B. Type A, there is autoimmune, and that goes for atrophic gastritis because the cells are almost it is dying because of the autoimmune process. And duodenogastric bile reflux also is a common cause, and gastric stasis and abnormalities in the acid pepsin secretion. So acid becomes ulcerogenic even to normal gastric mucosa, and additional factors, predisposing factors are smoking, alcohol, steroids, and NSAIDs. Helicobacter pylori is also commonest cause nowadays. It is the most common prevailing cause is about 70% of patients. Altered mucosal barrier mechanism and lower socioeconomic status. So what happens in the lower socioeconomic status? Diet becomes the most important predisposing factor. So old cooked food. So previously cooked food, cooked the day before yesterday or yesterday, that will be taken and there will be accumulation of bacteria along with the yeast formation, and that becomes the predisposing factor for injury. Already there is an ulcer or there is a mucosal barrier disruption. Whenever this bacteria in the old cooked food, and they used to have that with the kanji, they will sell kanji along with the melaha. So pachimalaha they will take because of these two, and that will cause injury to the already disturbed mucosal barrier. So that is a commonest cause. When you go for CA stomach, in the predisposing factor, we used to discuss that comes the major role, and that too because of the old cooked food. And next comes the nowadays people are taking most of the fast food items, burnt food, and all this charcoal containing burnt food. No, that is also the commonest reason for getting ulcer in low people, the low socioeconomic status, eating the old food. So factors involved in gastric ulcer formation is the duodenal gastric reflex. What happens here? Reflex of the bile salts and lysolecithin, both in the bile, that goes to the gastric area, and that disturbs the mucosal barrier, making it for vulnerable for the injury. Gastric stasis. So stasis means what? When because of the repeated ulcer, there ulceration going for stenosis occurs at the antrum and pyloric region, and stasis, and that produces the vicious cycle is going on. Ulceration, stasis, once again that induces injury to the gastric mucosal barrier, and ischemia of the gastric mucosa. So because of the repeated ulceration, what happens? The area becomes less vascularized, ischemia occurs. Type 2 and type 3 gastric ulcers, they show acid hypersecretion. I will show you the slide later. There are 4 types of gastric ulcer, type 1, 2, 3, 4. And among these, type 2 and 3 have excess gastric acid. And because of that, I'll show you the slide later. And what happens to the pathology is gastric ulcer, usually to be large in size, lies in the lesser curvature, and its floor is being formed by the mucosal layer. The superficial superficial layer, that is destroyed, and next comes the muscular layer. So the floor is formed by the muscular layer. Posteriorly, it can penetrate into the pancreas, and it may cause torrential bleeding because of the injury involving the involvement of the left gastric artery or splenic vessel, or in the vessels in the gastric ulcer wall. So what is the commonest vascular supply of the lesser curvature? It is supplied by the left gastric artery, and the greater curvature by the gastroepiploic vessels. And they send multiple branches inside the stomach. Vertical branches are there. So because of this ulcer, wherever the site is produced, the underlying posterior ulcer usually bleeds, anterior ulcer perforates. This is a common question we'll be asking in the clinical side. Anteriorly, ulcer can go for perforation, and that can even penetrate into the liver. Posteriorly, it will go narrowing of the lesser curvature that can lead on to deep pot deformity. And next is a hourglass contraction. The circumferential ulcer going for hourglass contraction. So the stomach will be divided into 2 portions, upper and lower portions, and because of the hourglass contraction. What happens? Gastric ulcer, whenever the ulcer size is more than 3 centimeter, we'll be calling it as a giant gastric ulcer. And grossly, margin of the gastric. So whenever you go through the margin, you can divide the ulcer. You can identify whether it is a benign ulcer or a malignant ulcer. So usually, margins of the benign gastric ulcer is clear, deep, and it will be near the lesser curvature. So lesser curvature ulcer will be mostly it will be benign, whereas the ulcers near the greater curvature, mostly it will be malignant. Okay, so the edges will be margin of the ulcer will be clear deep near the lesser curvature, and that is not everted. And with the gastric mucosal fold, that will be converging towards the base. So this is a very important clinical finding. When in the clinical side, no, whenever you go for practical examination, slides can be kept and the X-ray can also be kept with the barium meal X-ray. There you can see this clear evidence, and also in OGD scopy, no, OGD scopy means esophagogastric duodenoscopy, ordinary regular scopy, no. In the scopy also we can visualize this one, the normal regular clear ulcer edges along with the um, mucosal folds, no, gastric mucosal folds that will be converging towards the base of the ulcer. Edges will not be everted. This is very important clinical finding. 95% of the benign gastric ulcer occurs in the lesser curvature as it takes more burden of the past. Usually, you will be imagining that the food, no, it will be going towards the greater curvature whenever you eat, no. Usually, more of the water and a wear and tear effect occurs to the lesser curvature. It's a big burden of the stomach, and that is a common, that is a normal finding. Okay, so benign gastric ulcer is rare in the greater curvature. Otherwise, you can tell greater curvature ulcers are mostly malignant and lesser curvature mostly benign. And the ulcer in the greater curvature, fundus, cardia, usually they will be malignant. Benign gastric ulcers are rare in these areas. Acute ulcer, so it is confined to the mucosa and submucosa. It is competent into NSAIDs. Chronic ulcer, usually it will be penetrating the muscular layer of the stomach. So clinical features. What will be the clinical feature? It will be usually equal in both the sexes. Becomes more common in the becoming more common in females. Common after the age of 40 years. Commonest symptom patient will be telling is a pain. So epigastric region there will be pain after taking food and lasting for about almost a few hours. Sometimes 2 hours it will be pain. Uncommon, it is uncommon during nights, relieved by vomiting or by inducing vomiting. So periodicity, this is the important clinical feature, periodicity. That is symptom-free interval that can be about 2 to 6 months. So in peptic ulcer, this is very important clinical history when you evaluate. No, there will be periodicity. Gradually, this periodicity time will be narrowing in peptic ulcer. Whenever there is persistent pain, no, we can think in terms of malignancy. Persistent pain without any periodicity. Periodicity will be lost in the malignant ulcer. Whereas in peptic ulcer, there will be periodicity. Ulcer pain occurring with the symptom-free interval of 2 to 6 months. So our patient can have hematemesis, that is more common, and melena. So what do you mean by melena? Patient will be passing blood in the stool. So in the upper GIT bleeding, that is above the level of the second part of the duodenum, that is the upper GIT, and below the level it is the lower GIT. What happens in the upper GIT bleeding? Usually, patient the bleeding blood within the stomach can mix up with the acid within the stomach. So because of this, acid hematin is formed, and that when passes through the GIT, and it will be passed in the stool as melena. Melena is dark tarry stool. It will be sticky to the pan. So patient can identify this stickiness of the stool with the dark color, black tarry stool sticking to the pan, and it will be sometimes it will be smelling also. So that history is very important in bleeding within the ulcer. Ulcer, whenever there is ulcer, that can go on for bleeding. So because of repeated food intake and injury to the ulcer, there will be bleeding from the ulcer also. Superficial ulcer also can bleed, and that is present stool plus melena, having loss of weight. But once the complication occurs, what also decreases. Aversion to patient antrum, so near the lesser curvature is a type 1 gastric ulcer, and type 2 gastric ulcer is a combined gastric ulcer. It will be present both in the lesser curvature and also in the duodenal ulcer. And pre-pyloric ulcer becomes a type 3 gastric ulcer, and the type 4 is the ulcer in the proximal stomach or in the cardia. This picture shows the 4 types of gastric ulcer. So differential diagnosis, you can, whenever patient complains of pain in the epigastrium, we have to think in terms of other common clinical conditions like hiatus hernia, cholecystitis, chronic pancreatitis, and chronic gastritis, dyspepsia. Dyspepsia means there will be regurgitation of food, and the patient will have aversion to take food. There will be regurgitation of food. Substernal pain can occur, and very important clinical symptom can be carcinoma stomach. What are the common investigations? Barium meal X-ray. So that will be seen as niche and notch. Niching and notching. So this only I told. This is very important. Barium meal X-ray. I will show you. I think that slide is there. Gastroscopy is done to see the location, type of ulcer, and also to take biopsy. Usually, we will be taking 10 biopsy. So, what is the principle behind taking multiple biopsies? Means usually there are small ulcers. There will be area of bleeding from the ulcer, even from the edges, from the within the base of the ulcer, from the base everywhere ulcer can bleed. And so there will be necrosis also because of the food going. We are taking food and old cooked food, whatever, maybe there will be stasis. So food will be staying over the ulcer, and you can miss when if you are taking single biopsy, you can miss the important clinical finding of malignant features. So we have to take multiple ulcers. That center, usually whenever there is a large ulcer, center will go for necrosis because of the decreased vascularity, ischemia. The center portion of the ulcer can go for necrosis. So you have to take multiple ulcers to confirm your diagnosis. Usually we will be taken biopsy. Ultrasonogram of the abdomen is done mainly to rule out other diseases and to confirm the associated diseases. So barium meal. So this is a niche and notch. So what do you mean by niche and notch? And this is the picture. First is the picture, and the second is the picturization to understand. So niche is there is a small diverticulum, like there is a process inside, and notch means there is a small gap in the that is seen in the greater curvature. So niching and notching is an important clinical feature in barium meal study. Barium meal study is a very important clinical bedside. Not bedside, important investigation that is done in all hospitals. Nowadays, because of the availability of widespread availability of the gas, OGD scoping and CT scanning, this barium meal is almost, CT scan is replacing the barium meal. We are doing CT scan right and left with the contrast imaging that gives better picturization. Previously, we used to do only barium meal study to confirm because before the widespread use of the CT scan. So this is the gastroscopic picture showing the ulcer. You can see the ulcer and benign ulcer. There will be the rugosities will be clearly seen. In malignant ulcer, the rugosities from the edge of the ulcer, there will be normal rugosities will be lost in malignant ulcers. Okay. So gastric ulcer in the body of the stomach, gastric ulcer in the pre-pyloric region. These are the pictures. So treatment, usually drugs will be given. H2 blockers like ranitidine, cimetidine, proton pumping inhibitors, and biogastrin, sucralfate. Sucralfate is a mucosal anesthetic agent, and prostaglandins can also be given. Asymptomatic ulcer can lead to malignant transformation. Okay, but whenever there is pain, patient will be repeatedly coming to you or taking drugs. Whenever there is asymptomatic ulcers, that can turn on to malignancy. So surgery is the preferred treatment of choice. Partial gastrectomy and Billroth-1 gastroduodenal anastomosis can be done. So type 4 gastric ulcer, here the proximal gastric ulcer that is difficult to manage. The cardia will be ulcer will be present in the cardia also. It is treated by subtotal gastrectomy, type 4 gastritis. So usually we'll be doing distal gastrectomy with selective sleeve-like extension cut along the lesser curvature to remove the ulcer. That is called as Poucher's procedure. Nowadays, surgery doing for benign ulcer is almost decreasing. Whenever there is complication, gastric outlet obstruction, patient will be coming out. Whenever there is complication, we'll be doing planning for surgery. And this is the picture showing the stomach after doing distal gastrectomy. The distal portion of the stomach has been removed, and we are doing Billroth 1 anastomosis. Billroth 1 anastomosis means stomach will be anastomosed to the duodenum. So that is the next portion of the stomach. No, will be anastomosing stomach to the duodenum, and the lower portion of the cut end is seen, and that is anastomosed to the duodenum, and that is the Billroth 1 gastrectomy procedure. Okay. So the original Billroth operation that consisted of gastric resection with the gastroduodenal anastomosis. That is the Billroth 1 technique. In Billroth 2 gastrectomy, what we will do means we will be taking the jejunum, proximal portion of the jejunum is taken, and that is anastomosed to the stomach, cut end of the stomach. That is gastrojejunectomy. That is the Billroth 2 anastomosis. That is in relation to the, and that we will also be call it as polyogastrectomy. The anctum and the distal portion of the stomach are mobilized by opening the greater and lesser omentum, dividing the gastro epiploic arteries, and the right gastric artery and the left gastric artery are at the limit of resection. So duodenum is closed off either by suture and using stapler. Sometimes the difficulty in patients with we will be performing the duodenum now is mobilization will be difficult, so we'll be performing gastrojejunostomy. That is the better operation. Duodenum mobilization, bringing it towards the stomach, will be difficult in many of the cases, and that too, this Billroth 1 gastrectomy procedure, gastroduodenal anastomosis, is done mostly for benign procedures, benign diseases, not for malignant disease. So following resection, distal into the stomach is narrowed by closure of the lesser curvature. So this understanding, no, when you read once again for the before coming for the next class, if you have doubts, I can previously itself you just inform me. I can bring you pictures to show you. Okay. Nowadays it is shown in written form, no? So okay. This is the picture showing the distal portion of the stomach getting anastomosed to the jejunum. Okay, this is the Billroth 2. 2/3 of the stomach removed, and the duodenal stump is closed. Duodenal stump will be to the right of the stomach, and that is closed, and will be anastomosing the stomach to the jejunum. So what are the complications of gastric ulcer? Already we discussed now, hourglass contracture, teapot deformity that can occur. Hourglass contracture exclusively will be seen in women, and due to cicatricial contraction of the lesser curvature, here the stomach will be divided into two compartments. So barium male will be the diagnosis, easier for diagnosis, and here it shows filling only in the proximal stomach or double pouched stomach can be seen. Gastroscopy can also we can visualize the narrowing ones, and then there is another portion antrum just below the first narrowing that can be seen in the gastroscopy. Treatment is partial gastrectomy, wherein the gastric ulcer in the lower compartment of the stomach is almost removed, and if it is benign ulcer, we will be planning for Billroth 1 anastomosis. That is only we will be planning. Teapot deformity. Here the hang bag stomach bag will be the greater curvature will be hanging the narrowed lesser curvature. This is due to cicatrization and shortening of the lesser curvature. And they usually patient will be present with features of pylorexinosis. So we will be doing partial gastrectomy with Billroth 1 anastomosis. So see, we are discussing only the benign ulcers. CS stomach we are not discussing. So we are discussing about gastroduodenal, that is Billroth 1 anastomosis. Okay. Next is the perforation. This is the most common frequent clinical case we get because of duodenal ulcer or gastric ulcer that will be perforating. So bleeding by erosion of the left gastric ulcer in the case of gastric ulcers, or rarely the splenic vessels, and to the vessels in the wall of the ulcer. 33% is more common in type 2 and type 3 gastritis, and that is a common cause. That will be hyper acid secretion will be hyper. Malignant transformation usually to adenocarcinoma of the stomach usually occurs in 5 to 10%. Complications of gastric surgery. Kila.
Yes, ma'am.
எல்லாம் தூங்கியாச்சா? யாரெல்லாம் தூங்குனது? ஆண்டஸ், நிக்கோனர், அனுஷா,
Yes, ma'am.
ஆர்த்தி, அரவிந்தன். எல்லாம் முடிச்சிட்டு இருக்கீங்களா?
எஸ் மேம்.
ஓகே. அண்டர்ஸ்டாண்ட் பண்ண முடியுதா கிளாஸ்?
எஸ் மேம்.
ஓகே.
Yes,
யார்
ma'am.
சொல்றா? கரெக்டா சொல்றது. அஸ்வதி
Yes, ma'am.
ப்ரொசீட் பண்ணட்டா? இன்னும் டைம் இருக்கு. இட்ஸ் ஒன்லி 35. 9:35
Okay,
தானே
ma'am.
அது? 9:40 தானே அது? ஷால் ஐ கண்டினியூ?
Yes, ma'am.
தினேஷ், தைனேஷ், ஹாசினி,
எஸ் மேம்.
ஜெனிக்கர்
Yes,
இருக்கானா?
ma'am.
ஓகே. கண்டினியூ பண்ணிட்டா?
Yes, ma'am.
ஓகே. இன்னும் ஒரு 10-15 மினிட்ஸ்னா காம்ப்ளிகேஷன்ஸ் ஆஃப் கேஸ்ட்ரிக் சர்ஜரி நம்ம அப்படியே முடிச்சிடலாம் கம்ப்ளீட்டா. இல்ல உங்களுக்கு ரொம்ப போர் அடிக்குதுன்னா we can continue in another class. I am free only. ஒன்றும் ப்ராப்ளம் இல்லையே. கண்டினியூ பண்ணிட்டா? கார்த்திகா?
Ma'am.
ஓகே.
Yes,
கண்டினியூ
ma'am.
பண்றேன். ஓகேப்பா. ஓகே. வில் ஸ்டார்ட். வந்துச்சா? ஷேர் ஆகுதா?
எஸ் மேம்.
அருண்
எஸ்
ஷேர்
மேம்.
ஆகுதா? ஓகே.
ஆகுது மேம்.
ரைட். Okay, complication of gastric surgery. So we already discussed hemorrhage, stomal obstruction, both we already discussed. What comes here is a biliary after surgery. No, after surgery, what happens? There can be biliary fistula, injury to CBD, duodenal blowout on the fourth postoperative day, pancreatitis, recurrent ulcer, that is stomal ulcer, gastrojejunocolic fistula, dumping syndrome. Here, among these complications, hemorrhage is because of missing any bleeding vessel that can bleed inside and the patient can present with hematemesis postoperatively. Stomal obstruction. So when we are doing anastomosis, usually what will happen, the normal gastroduodenal passage, it will permit the food. When you are doing gastrojejunal anastomosis, you have to make sure that the jejunum accepts the food whatever the patient is taking. So the stoma has to be adequate to for the passage of the food. If the stoma is very narrow, also patient can get this stomal obstruction. Biliary fistula. Fistula means whenever there is communication between two spaces. No, that is only fistulous communication. This can also occur. So what happens? The injury to the CBD. Where comes the CBD? So whenever you are going to the first part of the duodenum, the CBD goes behind the first part of the duodenum. So injury can occur if you are doing inadvertent injury to the CBD can occur when you are mobilizing the first part of the duodenum. In duodenal anastomosis, duodenum is brought near the stomach and that is anastomosed. No? So that time also should be very careful to avoid injury to the duodenum. CBD. So injury to CBD can also occur. In malignant ulcer also, sometimes the ulcer will be very near to the anterior serosal layer and posterior near behind the stomach to the pancreas, and that portion of the duodenum will be very difficult for you to mobilize for closing the stump. Will be closing the duodenal stump in gastroduodenal Billroth 2 surgery. That duodenum will be closing. That time also we can injure CBD, which is going behind the first part of the duodenum. So duodenal blowout, this is the commonest complication that occurs in the fourth postoperative day, and that is because of inadequate closure of the duodenum. So I am telling whenever there is malignant ulcer and when you are mobilizing the serosal involvement in the gastric region, we have to take bite in the mobilization also will be difficult, and cutting the stomach end at the level of the first part of the duodenum also will be difficult. And what happens, you have to make sure you suture the duodenum properly in 2 layers. So when incomplete suturing occurs, duodenum can, because of stasis of the collection inside the duodenum, second and third part, it will be getting collected, and that can cause duodenal blowout. And we can avoid these complications by doing some alternative arrangements in the surgical procedure. That is, you could have heard of jejunostomy. What is the meaning of jejunostomy? Means we will be doing gastrojejunostomy, that is, stomach is anastomosed to the most proximal portion of the jejunum, and I will next class I will show you some pictures. You will understand. So that portion of the jejunum coming anastomose to the stomach, no, that will be anastomose to the nearby jejunum of the proximal portion of the jejunum. So a small jejunal-jejunalostomy will be doing that can prevent this duodenal blowout. And pancreatitis, because of the injury to the posterior, we are dissecting the stomach bed. No, pancreas is the next posterior organ that posterior to the stomach that can be injured and that can present with the pancreatitis. Recurrent ulcers and the stromal ulcers can occur. Gastrojejunocolic fistula and dumping syndrome combinations because of narrowed entry to the jejunum with the remaining portion of the stomach, no? And patient can have symptoms of fullness and that there are two types of dumping syndrome we'll discuss. So the patient can have nutritional disturbances, diarrhea, pulmonary tuberculosis, the immunity is lost, no? And the carcinoma in the gastric remnant can also occur after 10 to 15 years. Gallstone formation because of the bile disturbance, the passage disturbance, no? Alkaline gastritis can occur because of bile reflux into the stomach, afferent efferent loop syndrome. And this is also when you go to, today you go and read about gastric ulcer, you go to the gastrojejunal anastomosis pictures, look into it, and you will have so many doubts. So doubts can be discussed in the next class. Afferent means proximal to the proximal portion, different means distal portion. Both the loops can go for some complication, that is the afferent efferent loop syndrome. Afferent loop obstruction can also occur, that is the commonest, and efferent loop obstruction can also occur. So what are the early postoperative complications? So bleeding into the intraluminal from the stomal site or extraluminal, leak from the anastomotic line, delayed opening of the stoma, gastroparesis, duodenal stump blowout, lesser curvature necrosis, fistula formation, gastric duodenal jejunal and vomital infarction. Late postoperative complications, reflux gastritis, recurrence of the ulcer, dumping syndrome, malnutrition, all these are almost we are repeating. Small stomach syndrome, afferent efferent loop, retrograde jejunal intersusception can also occur, remnant carcinoma, gallstone. Okay, what do you mean by early dumping syndrome? It is very common, that's the most common severe type, and the incidence is about 10%. Vasomotor symptoms will appear after the intake of food, immediately after taking food. What happens? So it will be lasting for about 30 to 40 minutes. That is aggravated by bulky food. It is relieved by lying down. So the stomach portion is also small, and that is anastomosis, the narrow entry point, that is the jejunum. So whenever patient is taking food, no, so the advice to avoid this, patient has to take small frequent feeds. Small frequent means frequent feeds means, so according to the capacity of the stomach only, patient has to take food. That can be we can prevent this complication. It is relieved by lying down. So clinical features, there will be symptoms of parasympathetic overactivity, that is sweating, tachycardia, colic, diarrhea, hypotension, and features of hypovolemia because of diarrhea. So pathogenesis, primary disorders of carbohydrate metabolism, initial transient hyperglycemia that prevents further absorption of glucose because of excessive intake of food, no, that will cause hyperglycemia, and that will prevent further absorption of glucose. And this is the common complication. And this withdraws fluid because of the fluid withdrawal from the bowel wall, that will because of high osmolarity, and the patient can go for diarrhea. No, diarrhea is because of this only, resulting in increased intestinal activity that is leading to diarrhea and fall in blood volume. Hypovolemia can occur. And treatment is small, dry, more frequent food, that is avoidance of carbohydrate food. Excess of carbohydrate has to be avoided. Octreotide can be given, and that will reduce the secretion, that is given subcutaneously before meals, and that is found to be beneficial. Surgical treatment, conversion of Bilrath 2 to Bilrath 1 can be done, and next is the interposition of reversed jejunal loop, that is called as Henle's loop, and that is can also be tried. Early dumping syndrome can last for about a longer time. Many years patient can have, unless they understand the basic pathology behind and preventive techniques, and this patient will be going for these symptoms. So late dumping syndrome, it is of less severe type, incidence is only 5%, usually occurs 2 hours after taking food, and it's relieved by glucose and is aggravated by exercise. Here what will be the features means, patient will have tremor, fainting, and nausea, and you see this is because of hypoglycemia. First is because of hyperglycemia, and that prevents excessive oral carbohydrate intake, no, because of that hyperglycememia that prevents further absorption of glucose, and that only causes osmolarity changes and hypodiarrhea and hypovolemia. Here the entire pathology is different, and here there will be hypoglycemia and the symptoms of hypoglycemia, tremor, fainting, and nausea. Treatment is symptoms will be less severe and treated conservatively by giving glucose and food. So shall we close with this duodenal ulcer? I will look how many slides are there. Duodenal ulcer. Okay, Pa, shall we close? There's too much of subject now. Duodenal ulcer we can discuss in some other class. Okay. What is
Okay.
today's homework? What is today's homework? I will ask Vishnu Maya.
Ma'am.
Vishnu Maya இருக்கீங்க? என்ன ஹோம்வொர்க் கொடுக்கலாம் சொல்லு. இவ்வளவு நேரம் கண்டுபிடிச்சு படிச்சுட்டு வந்திருக்க ஃபைனல் இயர் ஸ்டூடெண்ட் எக்ஸாம் கோயிங்ல
Dumping syndrome.
சொல்லு. டம்பிங் சிண்ட்ரோம் காம்ப்ளிகேஷன் ஃபுல்லா ரீட் பண்ணிட்டு வாங்க. எல்லாம் ரீட் பண்ணிட்டு வாங்க. அதெல்லாம் எழுத வேண்டாம். யூ கேன் மேக் பிக்சர்ஸ் ஆஃப் gastrojejutinal and gastroduodenal anastomosis. Billroth 1 and Billroth 2 anastomosis we have discussed. No, you make pictures of these two and go through in your book, and it will be given clearly. Samira.
Okay, ma'am.
Samira.
Yes, ma'am.
வேற என்ன கொடுக்கலாம் சொல்லு ஹோம்வொர்க். So Billroth 1, Billroth 2 காம்ப்ளிகேஷன்ஸ்ல you have to read pictures போடுற மாதிரி ஏதாவது ஒண்ணு வச்சுக்கோங்க. என்ன போடலாம்? வேற என்ன பிக்சர்ஸ் உனக்கு சொல்லலாம்? நம்ம இன்னும் வேகாட்டமி எல்லாம் போடல. டியோடனல் அல்சர் போல இல்ல. வேகாட்டமி எல்லாம் படிச்சிருக்கீங்களா?
ஓகே மேம்.
ஆன்டீரியர் வேகஸ் எது, போஸ்டீரியர் வேகஸ் எது, வேகாட்டமில டைப்ஸ் எல்லாம் நெக்ஸ்ட் கிளாஸ் சொல்லுவாங்க. டியோடனல் அல்சரும் அதுக்கப்புறம் அதர் விஷயங்கள் கொஞ்சம் நம்ம டிஸ்கஸ் பண்ணிடலாம். சரியா? ஸோ நெக்ஸ்ட் கிளாஸ்ல அது வந்துடும். வேகாட்டமி, ட்ரங்கல் வேகாட்டமி, டைப்ஸ் ஆஃப் வேகாட்டமி எல்லாமே வந்துடும். ஓகேவா? க்ரோஸ் ஃபுட்னா என்ன அப்படிங்கறதெல்லாம் ஃபுல்லா நீங்க படிச்சிட்டீங்கன்னா உங்களுக்கு ஈஸியா இருக்கும் லிசன் பண்றப்ப. பூமணி, பொன்மணி.
ஹலோ மேம்.
போடுமா? இந்த நெக்ஸ்ட் இந்த 2 ஹோம்வொர்க் போடுமா?
ஓகே மேம்.
ஓகேவா? வேற ஏதாவது வேணும்னா சொல்லு. அடுத்த ஏதாவது ஹோம்வொர்க் கொடுப்போம். என்எஸ்ஐடிஸ் மற்றதெல்லாம் ஞாபகம் இருக்கா? ஃபார்மகாலஜில ரோல் ஆஃப் என்எஸ்ஐடிஸ், ட்ரீட்டிங் பிபிஐ கொடுத்து ட்ரீட் பண்ற வாட் இஸ் அ மெக்கானிசம், அதெல்லாம் ஞாபகம் இருக்கா? gastric outlet obstruction கிளாஸ் முடிஞ்சிருச்சா? benign gastric outlet obstruction because of benign disease முடிஞ்சிருச்சா? நோவா? என்னாச்சு, தூங்கிட்டு இருக்கியா பொன்மணி? அலர்ட் ஆன்சர் பண்ணு. நந்தகுமார், பொன்மணி தூங்கிட்டு இருக்கா. நந்தகுமார் இருக்கியா? முரளிதரன். அடுத்த 3வது ஹோம்வொர்க் சொல்றேன். மண்டே என்னோட நெக்ஸ்ட் கிளாஸ் இருக்கும். அதுக்குள்ள நீங்க இதெல்லாம் படிச்சுங்க. அப்பதான் நெக்ஸ்ட் கிளாஸ் நான் எடுப்பேன். ஹலோ
மேம் சொல்லுங்க.
சொல்லட்டா? நெக்ஸ்ட் ஹோம்வொர்க் என்னன்னு சொல்றேன். gastric outlet obstruction இருக்கும்ல, patient will be having vomiting in gastric outlet obstruction because of stasis of food.
ஓகே மேம்.
அதுல ஒரு கிளினிக்கல் ஒரு ப்ராப்ளம் வரும்ல, பேஷண்ட் எலக்ட்ரோலைட் இம்பேலன்ஸ் வரும்ல.
ஆமா.
அது படிச்சு வரீங்களா? வாட் இஸ் த பேசிஸ் ஆஃப் எலக்ட்ரோலைட் இம்பேலன்ஸ் இன் recurrent vomiting of gastric outlet obstruction?
சரி மேம்.
hyponatremia, hypokalemia, hypoclothemia, metabolic alkalosis. அது படிச்சுவீங்களா?
ஓகே மேம்.
அது படிச்சீங்கன்னா உங்களுக்கு அது அந்த நெக்ஸ்ட் டிஸ்கஷன் டியோடனல் அல்சர் டிஸ்கஷன்ல அது யூஸ்ஃபுல்லா இருக்கும். ஓகேவா? சரி, 3 ஹோம்வொர்க் கொடுத்திருக்கேன். அருண்குமார்.
எஸ் மேம்.
ஓகேப்பா. அருண்குமார்.
எஸ் மேம்.
இந்த ஹோம்வொர்க் என்னெல்லாம்ங்கறத நோட் பண்ணி வச்சுக்கோ. அட்டெண்டன்ஸ் கொடு. எனக்கு அட்டெண்டன்ஸ் கொடு. எத்தனை பேர் இருக்காங்க அட்டெண்டன்ஸ் சென்ட் பண்ணு. ஆப்சென்ட் இஸ் நேம் தனியா சென்ட் பண்ணு. ஆப்சென்டிஸ் நேம்
ஓகே
தனியா
மேம்.
சென்ட் பண்ணு. அட்டெண்டன்ஸ் ஃபுல்லாக
ஓகே
காப்பி போட்டு சரியா?
ஓகே.
அகிலா அகிலா அண்டர்ஸ்டாண்ட் பண்ணியா? புரிஞ்சுச்சா எல்லாம்?
எஸ் மேம்.
டவுட் இருந்தா கேட்கணும் சரியா? நெக்ஸ்ட் கிளாஸ்.
புரிஞ்சுச்சு மேம்.
ஓகேப்பா. ஓகே, தேங்க்யூமா.
ஷூர் மேம்.
ஓகேம்மா, தேங்க்யூ
Sure.
தேங்க்யூமா.
தேங்க்யூ மேம்.
தேங்க்யூ மேம்.